Dr. Ramdeep is joining. So today, Dr. Shayandeep Pradhan, who is a third-year DNB General Science resident at Vivekananda Institute of Medical Sciences, RKM Shivapadistan, will present the case. And with me, Dr. Ramdeep Rai, who is a hepatobiliary surgeon at Apollo Clinical Hospital, will also join. Dr. Shayandeep, you can share your screen and start presentation. And wait at the end of your history presentation. We'll discuss and then proceed for the examination. Shayandeep, please. So go here. Shayandeep, I cannot hear you. Shayandeep, please start. Dr. Ramdeep has joined. Yes.
Very sorry for being late.
No problem.
Yes, sir.
Yeah, Shayandeep.
Hello.
Yes, please start.
Yeah. Good morning, sir. Good morning, everyone. This is a case of obstructive jaundice, mainly due to choledocholithiasis. I am Dr. Shayandeep Pradhan, third-year PGT from Vivekananda Institute of Medical Sciences. Mr. XYZ, 62-year-old gentleman from Bankura, farmer by profession, presented with pain in right upper quadrant of abdomen for past 5 months, along with yellowish discoloration of eyes and urine since 2 months, associated with pruritus. In the history of present illness, the patient was apparently well 5 months back when he experienced severe pain in right upper quadrant of abdomen after taking fatty meal. The pain was severe in intensity, colicky in nature, radiating in back. It was associated with one episode of vomiting, which was non-projectile, mainly containing food particles. There was no history of fever. He took oral analgesics as well as antacids that were prescribed to him in such similar episodes twice in the past 1 year. The pain subsided 5 to 6 years after taking medications. For the past 2 months, the patient is having a constant dull aching pain in the right upper abdomen. He also noticed yellowish discoloration of urine, clay-colored stool for last 2 months. Subsequently, his wife noticed yellowish discoloration of eyes, which was insidious in onset, increasing in intensity. The jaundice as well as discoloration of urine and stool reduced to some extent in past 2 weeks. It was also associated with itching throughout the body since last 2 months, which has reduced to some extent in recent times. There is no history of hospitalization or endoscopy during this period. In the history of past illness, patient gives history of similar episodes of severe colicky pain abdomen twice in past 1 year. During the first episode, there was fever, jaundice, along with dark yellow urine and clay-colored stool. He was hospitalized at a local rural hospital where he was treated conservatively. His symptoms subsided eventually and was discharged with oral medication. He was advised for further follow-up at a higher center, which he didn't comply. He gives almost similar history while having his second episode of such symptoms. There is no history of endoscopy or surgical intervention in the past. In the personal history, patient is non-vegetarian, having Indian diet, no comorbidities. He is known smoker for the last 35 years. Sleep is disturbed due to itching. Family history, no history of similar illness in any member of the family, no history of cancer in the family. The parents died of natural death. There is no allergy history. In the general survey...
No, wait, Shayandeep, we'll have some discussion on the history presentation. Okay, because it's to some extent incomplete. Dr. Ramdev, you can start. The first thing I would say is he has a pain 1 year back. Okay. And then you started his treatment for 5 months. I think it should be better that you take this history to 1 year. Because 1 year back, he has got a classic pain, the jaundice, the subsidiary treatment, and then down the line after 5 or 6 months having pain. So it is better that don't take that 1 year history as past history. If it had been 2, 3, 4 years back, we have taken like that. So I would prefer that you take the history chief complaint as 1 year, and then describe the first episode, and then describe the second episode. That is one. Second is, don't get biased with what I said. Somebody told you choledocholithiasis. Because in the history, I don't find any other point apart from the pain and the jaundice. He's an elderly gentleman.
Yes, sir.
He may have a biliary colic. And then he presents jaundice. It can be carcinoma gallbladder.
Yes, sir.
Patient having recurrent biliary colic, then patient presenting with obstructive jaundice, we cannot definitely say that it is only choledocholithiasis. We might keep into consideration other possibilities. So obviously, you should take a good systemic history also. You should ask about his appetite, his weight loss, he has any features of gastric outlet obstruction. Okay. So if suspect is a malignancy, then you should think of asking some metastatic symptoms. Okay, Dr. Rai. You are not audible.
I'm saying something very stupid with a very small thing, but there's some examiners which again and again say that question, why did you write apparently well? It's a very MBBS thing right from beginning days, but they have this thing what apparent means it has to be appear. It's a visible thing. So there are people who say, there are examiners who say, how can you say that the patient was apparently well because patient was not apparent to you at that time? So some examiners are happy with this. Some examiners say that the patient did not have any health concerns or did not have any problems till 1 year back, which was when he started developing. That's another way of avoiding it. That is all. Okay. But I agree with what Makunda said, that this is I was also getting confused how to differentiate between that duration of 5 months and 1 year. So it would solve it by 1 year, definitely. I think so.
Yeah. Okay, Sandeep. So in the history, it should be comprehensive. You try to make a DD based on the history itself.
Okay.
So from the history, you can pick up points to justify the diet. Because examiner may ask you, why not carcinoma gallbladder in this patient? So you justify that patient has got a preserved appetite, does not have weight loss. Okay. And then there is no other features. Okay. So you take a comprehensive issue. Don't get biased with the diagnosis. You have to keep your history and everything open and cover all the systemic symptoms. Then pass on to examination. Yes.
In the JL survey, patient was examined with prior informed consent, adequate exposure in natural light, keeping private parts covered. Patient is alert, conscious, cooperative, average build with a BMI 19.23, hydration status normal, decubitors of choice, faces gait normal. There was no edema, sinuses clubbing, mild pallor was present, deep icterus present. Neck veins not engorged, neck glands not enlarged, lymph nodes not palpable, scratch marks of itching throughout the body noted, no visible peristalsis, pulsations, scar marks seen. Vitals, pulse 68 beats per minute, regular in rhythm, no special character, febrile, BP 116/70, respiratory rate 18 cycles per minute. In the locoregional examination, patient is supine, arms kept on sides and exposed from mid chest to mid thigh with genitalia covered, abdomen flat, umbilicus centrally placed, inverted, flanks not full, scratch marks of itching noted all over the abdomen, no scar marks or venous prominence seen, all quadrants moving equally with respiration. Palpation, In superficial palpation, temperature not raised, non-tender, all superficial reflexes elicited. In deep palpation, all deep reflexes are elicited. Liver, gallbladder, spleen not palpable.
Reflex.
Bilateral kidneys not palatable. No areas of tenderness found. No swelling in the supraclavicular fossa. Hernial orifices normal. Percussion, gel percussion note is tympanic all over the abdomen. No fluid thrill or shifting dullness seen. In auscultation, bowel sounds are heard. The systemic examination of the patient is found to be within the normal limits. Sir,
summarize.
Yeah.
Summary.
62-year-old gentleman presented in the OPD with features of obstructive jaundice along with pruritus following right upper quadrant pain. He had similar episodes of such symptoms in the past. On examination, there is mild pallor, icterus, deep icterus present. Abdominal examination found to be normal. So my provisional diagnosis is the patient suffering from obstructive jaundice, probably due to choledocholithiasis.
Go back to the picture of the patient.
Yes, you mark something on the picture.
Yes, I can see also. It's obviously seen also. There is a fullness, and you want to say that abdomen is normal. Yes, yes, here only. You see, there is. If you compare the two costal margin, obviously there is something in the right upper quadrant. How do you ignore that? And if you talk of nutrition, I can find this patient is not nutritionally preserved. You see the costal area. His prominent ribs. I don't think this gentleman of around 55, 60 years is nutritionally preserved. Okay, your finding should not vary. There is already, even if the marking is not there, I can make out there is some fullness in the right upper quadrant. What this might be? If this swelling is there, yes, how do you ascertain this is liver, this is gallbladder, this is a colonic mass? What? How do you ascertain?
Is this an actual patient whom you have examined, or?
Sir, this patient actually came to the OPD, but I didn't do the follow-up actually. This is in the different.
No, but this picture you have taken.
Yeah, my friend took actually.
Okay. Take it.
Oh, your friend forwarded. Then you should have noticed that there is a fullness. You see, the point that point what I was emphasizing. Patient may have classic history of colic and then obstructive jaundice, and you find abdominal lump like this. This can happen. In that case, there are ways to explain. It's not a situation that you never find a palpable gallbladder in choledocholithiasis. There are situations where you can find palpable gallbladder.
Yes, sir.
And then there are other ways to explain. There are other ways to explain the palpable gallbladder on the background of this choledocholithiasis also.
Yes, sir.
So you have to keep in mind these things. You cannot skip that. So you want to say that patient does not have a palpable gallbladder.
Okay, sir.
No, but right now, what are we proceeding with? Because you have shown this picture. So should we stick to this picture or should we disregard this? Because there is a very visible lump or mass, whatever. Shah, what do you think? We progress with a palpable mass or without a palpable?
Actually, he has given a scenario of choledocholithiasis. So he wanted to create a virtual case of choledocholithiasis that gallbladder is not palpable. But what I'm saying is, if you stick to this also, you just stick to this picture.
Yeah.
On the background of the colic, and this patient has got a palpable gallbladder, then we can discuss. You see, the idea of discussing this is a case as a long case where you may have varied presentation.
Yeah.
You may not find all the time patient has got choledocholithiasis and gallbladder is not palpable. You may have situations. So stick to this.
So let's
describe this lump.
So
on inspection, you describe this lump.
And when you're discussing this, keep in mind that I'm thinking that it's a lipoma. It can be a lipoma. It can be intra-abdominal mass. So keep that in mind with all possibilities. How do you differentiate when you're describing this?
Shandeep, you describe this swelling on inspection, how do you describe this? What are the things in inspection you consider? Dr. Ramdeep has picked out some extra-abdominal swelling also. So how do you describe this lump when you do an inspection of the abdomen? Yes, it's MBBS question, but still it's relevant for PGs also.
Sir,
describe this.
Sir, 3 into 3 centimeter.
How do you describe abdominal lump? Don't jump to the size. You should follow a basic step of describing a abdominal lump. What do you find? I can find a definite lump. Yes, and sir. Don't forget that right hypochondriac area is a very small thumb size area in the right upper quadrant. The remaining areas are different. If you draw the transparently plane and the mid-clavicular plane, you will find a very small area right hypochondria. Beyond that, you may have epigastrium, you may have umbilical, or may have the lumbar region. So you have to mark the area and then describe where is the swelling located. The first thing to describe is position and extent of the lump. Number one. Next is to describe, as Dr. Ramdeep has said, why not a lipoma? Why not a fibroma or a desmoid tumor in the right upper corner of the abdomen? So do a rising test. Do a rising test and look at this lump. If the lump is becoming less prominent, it is likely to be intra-abdominal. So ascertain that. And once ascertain that, then describe the shape and then the size. See, lump description has a method to be described. The first thing to describe is position and extent. In abdomen, confirm whether it is intra-abdominal or parietal. Don't do a knee elbow to confirm retroperitoneal. That is not being done now. It's an awkward position for the patient. Okay. And then describe the shape, size. You see the surface. How do you feel the surface is?
By palpation, sir?
No, by inspection. I'm doing inspection. It's a definite swelling seen in the upper quadrant. The surface appears smooth.
Yes, sir.
What about borders? You ask the patient to get deep breaths. And in this position, it is difficult to say about the borders. It is not possible to ascertain the borders on just inspecting a static picture. You ask the patient to take breaths. Once he's breathing, if the swelling is moving up and down with respiration, which is likely in a patient who has got a palpable gallbladder or a enlarged liver, you may make out the margins. So surface and margin. And then you have described the skin over the abdomen. That's it. Beyond that, the descriptions are required. On palpation, what is the characteristics of a gallbladder mass? When you palpate, when you say, yes, on palpation, I can corroborate that this is a gallbladder lump. What are the characteristics of a gallbladder lump?
So it is globular, firm, moves with respiration, sir.
There are very important points to justify a diagnosis of gallbladder lump. What about, how do you differentiate a gallbladder lump from the enlarged liver? Suppose liver is the right liver which is enlarging.
Sir, I have to insinuate my fingers.
No. Even in gallbladder lump, we cannot insinuate. The gallbladder lump is in close relation to the inferior surface of the liver.
Yes.
What is important in gallbladder lump is basically first is intra-abdominal lump, number one. Number two, if it is a gallbladder lump, you will find patient has got a definite lower border of the lump. Patient has got a clear medial border of the lump. Patient has got a lateral border of the lump. And if you come to the upper border passes under the costal margin. If it is a enlarged liver, it will have a linear border. Try to understand. In a enlarged liver, if the right lobe enlarges, you will not find there is a cleavage and you find a definite medial border. That is not there if it is an enlarged liver. And as I said, the region may vary. It can start in the hypochondrium and then pass on to the adjacent regions. Okay. Hand insufflation is not possible even in a gallbladder lump. So if you find a gallbladder lump, try to understand how to describe. And you said firm. It may not be always firm. A patient having a carcinoma gallbladder, it may appear hard even. But it is difficult to make out a tense cystic and firm gallbladder in the intra-abdominal part. But more important is you have to describe the surface. If it is a carcinoma gallbladder, the surface, the whole lump may appear irregular.
Irregular, sir.
If it is a distended gallbladder because of biliary obstruction distally, it is usually a smooth outline of the gallbladder. Okay, you can feel the margin, you can feel the surface being smooth. So keeping in mind this enlarged gallbladder, we pass on to the diagnosis. So there is no, how do you justify this patient has got obstructive jaundice?
Sir,
so also you have to decide whether the palpable finding is it a firm gallbladder or a hard gallbladder?
Yes.
So that you have to commit at this point.
yes.
What do you expect? Suppose you are, because you have not gone to the other symptoms of weight loss, anorexia and other things,
Yes.
they are not there. I assume that patient has got preserved appetite and he does not have a significant weight loss in this period of time.
Okay, sir.
And then you see the surface appears smooth.
Yes, sir.
So if you take this patient as a firm gallbladder, it's okay. Firm may go either way. You see, if you say firm, you are safe on either way. It can be towards malignancy, it can be towards benign condition. But once you commit is hard and irregular, you commit that is likely to be neoplastic. So stick to firm and then try to defend the next part. So why it is obstructive jaundice? What are the features in this patient to suggest that this patient is suffering obstructive jaundice?
Sir, the patient is having yellowish discoloration of urine along with clay-colored stool, sir.
Yes. Another thing I mentioned in chief complaint even.
Pruritus, sir.
Yes. So these are the
features of
two important points that jaundice is obstructive.
Obstructive jaundice.
Why clay-colored stool is there in the patient obstructive jaundice? What is the explanation?
Sir, due to obstruction in the bile duct, the bile does not flow into the intestine, for which the starcobilin, that is mainly that gives the color of the stool, is not present.
Does the bile contain starcobilin?
No, sir.
Bile contains what? What is the pigment in the bile?
Starcobilinogen and urobilinogen.
No, starcobilin is not there in the bile. The bile pigment is bilirubin.
Bilirubin, sir. Bilirubin, sir.
So that goes to intestine.
And gets.
What happens to this bilirubin?
So it gets means the gut flora acts on the bilirubin and forms urobilinogen and starcobilinogen, sir.
And then?
And sir, that starcobilinogen goes to the
stool. So in the bile you don't have starcobilin or starcobilinogen. You have the bile pigments.
Yes, sir.
Why patient has pruritus?
Sir, it is due to the deposition of bile salts in the free nerve endings of the dermis, sir.
Any other explanation?
Release of histamine.
Yes, histamine-like products.
Yes, sir.
Which can cause local itching.
Yes.
Yeah, Dr. Rai, please proceed.
Yeah. So the patient has jaundice because there is yellowing of skin and sclera.
Yes, sir.
Patient has obstructive jaundice because there is the high-colored urine, clay-colored stools, and itching.
Yes, sir.
Okay. Now, what do you think is the reason for the obstructive jaundice?
Sir, in this patient, sir.
Provisional diagnosis?
Yeah, this patient only. Yes.
Choledocholithiasis, sir.
Only.
So that is your provisional diagnosis.
Yes, sir.
And if there is choledocholithiasis, then why is the gallbladder palpable?
Sir, there are a few exceptions where in stones, the gallbladder may be palpable, like, sir, in double impaction of stone.
Okay. Okay. So should he mention only obstructive jaundice due to choledocholithiasis or as a provisional diagnosis, or should he mention something in the gallbladder as also as part of the provisional
Yes,
diagnosis?
he should, because the patient has got previous attacks of biliary colics.
Yes.
And he has not underwent any surgery for the gallbladder. So it should be a patient having cholecystitis, choledocholithiasis, and choledocholithiasis. So there might be a stone disease in the gallbladder itself, which has migrated to the biliary tree.
Yeah.
Because he has got previous attacks of biliary colics.
Yes.
So obstructive jaundice due to chronic cholecystitis complicated with probably choledocholithiasis.
Yes.
This is your provisional clinical diagnosis.
Okay.
Yes.
What are your differential diagnosis?
Yes. Differential diagnosis. You cannot stick to single diagnosis on the background of gallbladder being palpable.
Sir, there can be, sir, malignant conditions like periampullary carcinoma.
So my differential diagnosis include obstructive jaundice due to, because you will not move away in your differential diagnosis from obstructive jaundice because that is established.
Yes,
so
sir.
now it is obstructive jaundice due to. What are the possibilities?
Sir, periampullary carcinoma, sir.
Okay.
Carcinoma head of pancreas, sir.
Okay.
Then choledocholithiasis, sir.
So one is periampullary group of cancers.
Yes, sir.
One. Which includes what?
Which includes carcinoma head of pancreas.
Whole of head. Whole of head. There is a definition for defining periampullary group of tumors. It is from the head within 2 centimeters of the ampulla. It's not the whole head proper. Yes. That is a different entity. What else in the periampullary tumor? One is head within 2 centimeters of the ampulla. Second is we should be knowing the periampullary tumors.
Yes, sir.
It's a tumor from the ampulla itself.
Ampulla itself, yes, sir.
And distal CBD?
Distal and duodenum, sir.
Yes. And duodenum where? Around the ampulla.
Around the.
So if you want to define a periampullary tumor, group of tumors, these are the tumors arising from the head within 2 centimeters of the ampulla, ampulla proper, distal CBD within 2 centimeters of the ampulla, and the duodenum around the ampulla. That is the definition for periampullary tumor. What else may be the site for malignancy in this patient? And keep in mind, you are having a patient having a palpable gallbladder. Don't jump to a Claskin tumor in this patient.
Yes, sir.
In Claskin tumor, you can explain the palpable gallbladder. So tell us some more diagnosis where you may have obstructive jaundice with a palpable gallbladder. Carcinoma gallbladder is very common in this part of the country. Patient having gallstone disease, yes, it should be there in the DD. But you exclude by saying that patient has got a smooth gallbladder, patient has got a tense cystic or a firm gallbladder, so patient has preserved appetite, no weight loss.
Yes.
Because you say the patient has got the change of character of pain, which can happen in the impacted stone, that is true. But patient having a neoplastic change may also have a change of character of pain. So don't be very rigid in the examination. You should be flexible that you could, but don't consider a wild diagnosis like hydrated cyst of the liver in this patient. Okay, so stick to the findings you have and stick to the points you have in the history and examination. Yes, Dr. Rai?
Yeah. So what are the other things besides periampullary cancers? What are the other differential diagnoses? As Dr. Shah was asking,
gallbladder carcinoma, cholangio.
It can be a differential diagnosis. Yes, cholangio. What?
Cholangiocarcinoma, sir.
Where? Of which part of the bile duct?
Supradural part of the
gallbladder being palpable, the answer should be infracystic. Infracystic biliary tree. Because above the cystic duct, you will not find a palpable gallbladder usually. Then Can it be a extrinsic compression in the biliary tree?
Yes, sir. From the metastatic nodes, lymph nodes, or in case of any tuberculosis, sir.
Okay, keep in mind this. How do you like to proceed for managing this patient?
Sir, I want to do some investigations to confirm my diagnosis. In the investigation, I will do routine blood examinations involving.
You see, Shayandeep, this is a PG level examination.
Yes, sir.
It's a PG level examination. If you start with the statement, I would like to do investigation to confirm the diagnosis. A routine blood examination does not corroborate for your confirming the diagnosis. So be very focused. Be very focused. How do you start describing the investigations? So
I will do some routine examinations and some.
Don't say routine. You said it's a investigation to confirm the diagnosis. The first thing should be confirm the diagnosis of obstructive jaundice.
Yes, sir.
Why do you say routine blood? Here LFT is not routine. Here LFT is one of the important investigation to confirm your corroboration of whether it is obstructive or it is a hepatocellular or it is hemolytic jaundice.
Yes, sir.
So what are the features in LFT to say yes, this is a classic appearance of obstructive jaundice in LFT?
So the conjugated, the direct hemoglobin is increased.
Yes.
Then there will be increase in alkaline phosphatase. There will be increase in GGT also, sir.
Yes. What about ALT/AST?
So it may be raised in later stages, sir.
But if you compare with the viral hepatitis versus obstructive jaundice, what would be this ALT/AST values?
With respect to viral hepatitis, sir, ALT/AST will not be raised.
Viral hepatitis has got a cholestatic phase. Don't forget.
Yes, sir.
In viral hepatitis, this ALT/AST may go to very high levels,
yes,
maybe 2,000, 3,000, 5,000. In obstructive jaundice, usually ALT/AST is not altered. But if it is altered at all, there is mild elevation of ALT/AST. You won't find a patient of obstructive jaundice having a ALT/AST of 2,000 or 3,000, 5,000. That indicates very advanced liver disease.
Yes,
okay. So obstructive jaundice, first is LFT. Next, stick to your point of confirming the diagnosis.
Second, sir,
you have to say that I expect the patient to have predominantly conjugated hyperbilirubinemia with a disproportionately high, with a rise in liver enzymes, a disproportionately high rise of alkaline phosphatase and GGT as compared to a possible small rise of ALT/AST.
Yes. So that's with the statement for justifying obstructive jaundice.
Yeah. And then the question is, why do you expect the alkaline phosphatase and GGT to rise in this case? Why do you not expect the ALT/AST to rise?
Because, sir, there is an obstruction in the bile duct, and ALT, GGT are mainly secreted from the bile duct. So
yeah, so the statement to say is that alkaline phosphatase and GGT are expected to be raised because these are markers of bile duct epithelial damage, as opposed to SGOT and SGPT, which are markers of hepatocellular damage or hepatocyte damage. Okay. Yeah. Then, besides liver function test, the next report what I like to see is,
sir, the radiological ultrasonography.
No, blood test.
Achha,
the blood test.
PTINR coagulation profile.
You just don't say that. I would like to look at the INR report. And in cases of obstructive jaundice, very often we would find a deranged INR. That INR would be prolonged.
Yes, sir.
Okay.
What would you do if a patient has an INR while you are, probably advising some investigations?
Yes, sir.
Patient will go back, get an ultrasound, come back after 2 days, 1 day. What would be the first thing you would advise in a patient with INR being elevated? Any medicines?
Sir, vitamin K, sir. Vitamin K we give for IM for 3 to 5 days.
Okay. IM or IV?
IM or IV. And if the INR is not does not come to the normal level, then we can go for fresh frozen plasma.
That's it.
Oh,
okay. So yeah. So any other blood tests?
So we will also go for the complete hemogram and renal function test.
What do you want to see in the complete hemogram?
So the hemoglobin level, and if the total count of the patient in case of any infection that may be that may be raised, and also the platelet counts.
Why?
Because,
so yes. Anything? So what you can say is, in a patient of obstructive jaundice, we would like to look at the complete blood count as well. The hemoglobin may be deranged, may be low in patients with malignancy, or the hemoglobin will be low in cases of obstructive jaundice where there has been bleeding. For example, for an ampullary malignancy, if there is bleeding, then it may. The patients with anemia and jaundice may also have other non-obstructive causes of jaundice, but in this case, we are looking at obstructive jaundice. You have to look at the white cell count, because the white cell count may be elevated in patients with infection like cholangitis, in which case it may go into 22,000, 25,000, very high. And you also have to look at the platelet counts, because if the platelet counts are extremely low, then it may be that the jaundice is because of an underlying liver disease or portal hypertension. So all three are important. Next.
So we asked for ultrasonography. He came back with the report.
Yes, sir.
What are the important things you look in the ultrasound report for assessing a patient? It's a very basic and very important investigation, which scores more than a CT scan. So tell us, what are the things you expect in this patient with a provisional diagnosis of choledocholithiasis?
Sir, I will expect a patient with obstructive jaundice in this patient with gallbladder calculi along with a CBD calculi, or just a CBD calculi blocking the CBD bile duct. I will also see the diameter of the CBD and condition of the gallbladder also.
What else? In the liver?
Yes, sir. Liver condition as well also.
What in the liver you see itself, apart from the liver enlargement? What happens to the...
If there is any dilated intrahepatic biliary radicals.
Yes, that is very important.
Yes, sir.
So the ultrasound will confirm that the swelling that I have palpated is a gallbladder swelling, or the gallbladder is enlarged. That will confirm. It may say that no, it's actually a colon mass.
Yes.
Okay, so the other possibility. So your findings will be confirmed. So ultrasound confirms that.
Yes.
Then it shows that it's a enlarged gallbladder. It shows whether the gallbladder has any stones or any neoplasm or anything inside. It shows the thickness of the gallbladder wall. It shows whether the gallbladder wall is thick. There is evidence of edema. There is evidence of pericholecystic fluid. It shows whether the stone is impacted and causing a dilatation. It also comments on the bile duct, whether the bile duct is of normal diameter or it is enlarged or dilated, and whether there are stones inside the bile duct, single stone or multiple stones. It also says whether there is anything, whether the liver looks normal, the liver parenchyma is normal. It shows whether there is liver is enlarged, whether there is intrahepatic biliary radical dilatation or IHBRD, and it shows evidence of any deposits, any evidence of metastasis in the liver, or any evidence of abscesses in the liver. If the patient has fever, jaundice, along with bile duct stones, sometimes you can also find cholangitis abscesses. So all these things.
I'll give you a scenario. This patient report came back saying gallbladder wall is thickened there are multiple stones in the gallbladder. CBD is 10 millimeter, but no stone can be seen in the CBD and no mass lesion can be seen in the periampullary region. You got my report?
Yes, sir.
You got this report. What should be your next step? Patient has got an enlarged gallbladder. What inpatient do you ask next and justify that?
So I will go for MRCP, sir.
MRCP, why?
Because, sir, the CBD is dilated. There is stone in the gallbladder, and sir, in USG, the supraduodenal part of the gallbladder is seen better. So there may be gas shadows that have the poor window for the USG, and MRCP delineates the whole of the biliary system.
I agree with your approach. It will be MRCP, but the point should be like this. These patients are, I have got a strong suspicion of stone disease. As such, there is no symptom suggestive of neoplastic disease in this patient, and a stone in the distal CBD may be missed on ultrasonography.
Yes, sir.
So I prefer to do MRCP because you have to justify. Because if you have a strong suspicion of malignancy in this patient, at this point of time, with this finding, I would have gone for triphasic CCT.
Triphasic CCT.
Because your examination of the patient, your guidance by, because the subsequent investigation is guided by ultrasonography. Yes, and your clinical background. MRCP has shown there is a stone of 2 centimeters in the distal CBD, in the retroduodenal part, 2 centimeter size stone. What should be your approach? What would you do in this patient? 2 centimeter size CBD stone with gallstone. What should be your planning for this patient? You like to do a CT?
No, sir. CT scan is of no value at present.
So if you have a clinical situation of no suspicion of malignancy, if you have a ultrasound report of like this, and then you find a stone disease with a large stone in the CBD, CT will not help much in this situation.
Yes, sir.
What should be your line of management in this patient with the background of this report?
Sir, 2 centimeter stones are the patient may be taken for ERCP and stone removal. Hello.
Yes. So should you say that, or should you, sir, first say that you'll now discuss the diagnosis with the patient and what are the options of management, and then you will probably any other investigations that should be done? So probably the diagnosis is complete as of now, and you only need some basic investigations to prepare the patient for ERCP, maybe. But otherwise, you just need to discuss the procedure and the plan with the patient. Okay.
Yes, sir.
If it is a 2 centimeter stone, what counseling you should do and what should be your approach? Because all endoscopists will not be able to take this 2 centimeter stone out easily. Sir. Understand?
Yes, sir. So I will counsel the patient about the failure of.
Then what facility should be there with ERCP to remove such a stone? What facility should be there with endoscopist?
Lithotripsy.
Yes. Nobody can remove a intact 2 centimeter stone to the ampulla. It's not possible.
Yes, sir.
So you should consider this patient on ERCP, provided the endoscopist has a facility for doing lithotripsy during the procedure.
Yes, sir.
So you will say that on the MRI or MRCP, we have identified a 2 centimeter stone impacted in the lower end of the bile duct, and the MRI does not show any other mass lesion around that area. So now my diagnosis is confirmed that it is obstructive jaundice with cholecystitis and an impacted gallbladder CBD stone in the lower extremity. So now I will discuss this diagnosis with the patient, and suggest ERCP with or without lithotripsy as the management of this condition.
Yes,
I will discuss this with the gastroenterologist, and if ERCP is possible, then after necessary investigations, which may include an chest X-ray and an ECG as well, because if they need to give anesthesia or fitness, we would plan this patient for the ERCP. However, the patient needs to be counseled that there is a significant chance that it may not be possible to extract a large bile stone. If ERCP is attempted, then in some cases, they would just put in a stent and come out, and later surgically that stone is taken out, or lithotripsy is done and taken out.
Yes.
What other option you'll discuss apart from ERCP? What may be the other options for management of this patient? One is ERCP, followed by lap cholecystectomy. Next option. You're in a good center. You have all the facilities. You have open surgeon, you have lap surgeon, you have everyone around you. What should be the next best option for this patient?
So lap choledochotomy and stone extraction.
This is a patient in front of you. Don't give an incomplete diagnosis. This will go in the choledochotomy, stone extraction, and come out. That's it. You leave behind the gallbladder.
No, sir.
No, give a complete answer. It can be a laparoscopic approach. Now it is an established procedure. Yes, now laparoscopic CBD exploration at the same sitting with lap cholecystectomy is the standard of care.
Yes, sir.
So that is another option.
Yes, sir.
Third option is?
If that fails, sir, then open cholecystectomy with CBD clearance, sir.
Okay, so these are the options for this patient.
Yes, sir.
Okay, so patient has opted for ERCP and stone extraction.
Yes, sir.
How will you prepare this patient for some invasive procedure? You just cannot send the patient for ERCP without assessing his other parameters.
Yes, sir. First I will see the I'll do all the routine examinations. I will see the coagulation profile. I will give vitamin K if required, if the INR is raised. Then I'll
because that is must. In ERCP, you are going to do sphincterotomy.
Yes, sir.
If it is a ERCP for stone extraction, you need to have sphincterotomy. And if INR is prolonged, this patient will have bleeding.
Bleeding, sir.
On sphincterotomy. So it is difficult to control that. So each patient should be optimized. And now you are planning for surgical intervention. Maybe a laparoscopy or open surgery. What are the different aspects of preparing a patient of obstructive jaundice for surgery? What are the different steps for preparing the patient? Patient is, I find patient not nutritionally preserved also.
Sir, I will see the albumin level of the patient.
Albumin level is low. It is 2.8. How do you do?
Then I'll give oral high protein diet with protein powders.
Patient is admitted. Do you think giving oral protein diet for 1 or 2 days will correct this? What does it indicate? The albumin level is low.
Yes, sir.
What does it implies?
That the nutrition of the patient is not good.
And it's a chronic malnutrition.
Chronic malnutrition. Yes, sir.
So you have correctly not answered. I'll give albumin transfusion. That is not the answer. Albumin being low, the answer is not giving albumin transfusion. It's a global nutritional deficit. So if the time is there, you can start with oral, or you need to operate early. You should give the patient parenteral nutrition.
Parenteral nutrition.
The best is oral nutrition, but if you consider to do surgery early, albumin is not the answer. You should give the patient a full nutritional supplement.
Yes, sir.
What else? One is nutrition build-up. Second, you said patient has got pallor.
Sir, I will go see the hemoglobin level. If it is less, then I'll go for blood transfusion. If the patient needs emergency surgery, or I can give oral hematinics.
This patient having cholangitis with CBD stone, you cannot discharge home by giving hematinics. Will take about 2 to 4 weeks time to increase hemoglobin. So this patient admitted in the surgical ward will not be relying on oral hematotics.
Yes, sir.
So this should be corrected by PRBC transfusion.
PRBC transfusion.
What else? Other preparations.
So I will give on IV antibiotics, sir.
Why?
So because there is a chronic cholecystitis, so to reduce the inflammation.
What do you think of the bile in this patient? Sterile or bile should be infected on the background of CVD stone?
So infected, sir.
Yes, the bile contains some flora. On the background of stone, you expect that the bile will be infected.
Yes, sir.
And these are the patient who may develop gram-negative sepsis in the immediate post-op period.
Yes, sir.
So this patient should be given antibiotics. Broad-spectrum antibiotics covering all the biliary pathogen. Yes, what else? You are not answering another important aspect of this patient in preparation.
Hydration, sir.
Yes. Why hydration is important? Why hydration is important? What complication can happen in the post-op period in a patient who has got obstructive jaundice? Is a defined complication post-operatively in a patient with obstructive jaundice described as
pancreatitis.
Pancreatitis. That is related to the hydration.
Post-op, sir.
Hepatorenal syndrome. These are the patients who can go to acute renal failure. Both hydration and sepsis. These two combined are important for genesis of hepatorenal syndrome.
Okay,
so these patients should be well hydrated.
Well hydrated.
Okay, how do you know patient is well hydrated? What are the markers for patient being adequately hydrated? You said patient has no dehydration. How you have assessed that? How you have assessed that?
Sir, by seeing the skin turgor.
Before that? Before skin turgor?
Tongue, sir. Tongue moist or dry.
Patient who is dehydrated will be thirsty.
Yes.
First is history.
Okay.
Any reason to suspect? For example, as he said, that continually patient is thirsty, or if there is vomiting, that will make you suspect dehydration. If the urine output has been inadequate, that will make you suspect. And then on inspection.
On general appearance, you may find the patient has got sunken eyes. Okay, you can find a dry tongue.
Dry tongue. Yes.
Okay, dry conjunctiva, lips. And then go for skin turgor. Examine for the pulse. And then what is the objective assessment for hydration? Objective assessment? This is urine output.
Yes.
At what urine output you are happy that patient is well hydrated? At what urine output you are happy that patient is well hydrated? What is the optimal urine output? Patient is well hydrated?
In said 24 hours.
Per hour.
You can go by hour.
No.
How many milliliters per hour?
40 to 50.
40 to 50. There is nothing like that. There is a 1 ml per kg per hour is the optimal urine output when you can say the patient is well hydrated.
Okay, sir.
Okay. The optimal urine output is described as 0.5 to 1 ml per kg per hour. That is the urine output. 1 ml means you are happy that patient is well hydrated.
Yes, sir.
So you don't forget about the preparation of a patient who has got obstructive jaundice. Okay, so prepare this patient. And now you have decided for a laparoscopic surgery.
Yes, sir.
For CBD stone and gallstone.
Morning.
Yeah. So there's a student who's asking, can you please repeat the significance of adequate hydration?
Okay, once the patients are dehydrated and you take this patient for surgery, this patient may have a situation of renal perfusion being less. And on the background of this cholangitis, patient may be in sepsis. And if the patient has got paraoperative hypovolemia, these are the patients who can go to acute renal failure. And these are the patients who are already jaundiced. They are the patient who can go to hepatic failure. And this is a described entity in a patient who has got obstructive jaundice undergoing surgery. So these patients may develop hepatorenal syndrome because of dehydration, causing less renal perfusion, and this patient may have hepatic failure because of aggravation of this hepatic insult. So adequate hydration is important.
Yes,
Okay.
so we were on the preparation
for
surgery.
Yes, sir.
So now you're preparing for surgery.
Yes, sir.
Anything else?
Coagulation profile you already talked. Coagulation profile should be corrected. If there is a prolonged INR, you should give the patient vitamin K, and if not cut by vitamin K, you need to give the patient fresh frozen plasma.
Yes, sir.
So the other specific preparation for obstructive jaundice, then you have to consider the general preparation. You should take the other parameters to in consideration, cardiac, respiratory, and other preparations. So you have decided to do a laparoscopic surgery in this patient.
Yes, sir.
How will you proceed? Give us salient points in laparoscopic surgery for gallstone and CBD stone in this patient. What facility you should have if you want to approach this patient with for laparoscopic surgery? What facility you should have there in the theater apart from just a routine laparoscope set?
The intraoperative cholangiograms.
That is one. What else? More advanced gadget.
Choledocoscope.
Yes, choledocoscope.
Yes, sir.
That is a very important additive for this laparoscopic set in the theater, because you can pass this choledocoscope into the biliary tree and look at the bile duct. And if you find a stone is being left behind, you can take the stone out to the choledocoscope also.
Yes, sir.
Okay. So any salient steps for doing this lab CBD exploration?
Salient steps.
Salient step, how do you proceed? You are doing lab cholecystectomy, lab CBD exploration. What are you going to do first? First approach the gallbladder, first approach the CBD.
Sir, first approach the gallbladder, sir.
What do? You remove the whole gallbladder?
No, sir. I will do.
Have you seen this procedure being done laparoscopically, or you have seen a video?
No, sir.
You have to see. At least you see a video now. Everything is available in the YouTube. So you try to dissect the cystic duct, because if you have multiple stones in the gallbladder, and intraoperative manipulation also may lead to some stone being slipped into the bile duct.
Yes, sir.
So the best thing is to dissect the cystic pedicle, pass a ligature around the cystic duct, or you can clip the cystic duct. You can keep the gallbladder for traction while doing choledochotomy. Okay?
Yes, sir.
So where you do the choledochotomy? If you take the bile duct, where will you place the choledochotomy?
Longitudinal incision, sir.
Yes. Where? Which part of bile duct you will make the choledochotomy opening? Classic area for doing choledochotomy.
Sir, except the 3 o'clock and 9 o'clock during the anterior. Because from
that is a site in the bile. Yes. So where it is? If it is not in 3 or 9 o'clock, where you place that? Where do you place it? Even for the open surgery is same. It is classically 12 o'clock.
12 o'clock, sir.
In between 3 and 9 o'clock. 12 o'clock. Where is the lower end of the cut? Lower end of the cut is where?
I don't.
Where is the duodenum? it should be in the supraduodenal part. You should not take the incision behind the duodenum, because behind the duodenum, you go down, you will find the pancreas. So it should be the supraduodenal colorectomy. And ideal colorectomy is start with 2 centimeter incision.
Yes, sir.
Okay. How you remove the stone? Laparoscopically. What are the techniques to remove the stones during laparoscopy? कैसे remove करता है? You must see a laparoscopy procedure.
Yes.
One is, once you make the colorectomy, some stone may come out easily.
Yes, sir.
Next is irrigate. You take a suction irrigation cannula and keep on irrigating. This irrigation can cause expulsion of this.
Yes, sir.
Or you can pass a instrument. You can use a Maryland or a bowel grasper to remove the stone.
Yes, sir.
And then how will you confirm at the end you have done a complete clearance of CVD? What is the measures to confirm that I have done a complete clearance? You have no scope of palpating the CBD like open surgery. How will you confirm?
Intraoperative cholangiogram, sir.
The whole bile duct is open. How will you do it?
Two ways of doing it. One is, you yourself said, what is the other instrument that you have?
Choledocoscope, sir.
So either by choledocoscopy or by cholangiography, or both.
Yes. But once the CBD is open, you try to understand. Once the CBD is open, you cannot inject contrast into the CBD unless you close the CBD, put a catheter, T-tube, then you do it. The best thing in this situation, when the CBD is wide open, 2 centimeter, you cannot pass contrast. Contrast will all extravasate outside. So in that case, the best gadget should be, I will do a choledocoscopy to confirm. If I'm doing laparoscopy, try to understand.
Yes, sir.
In open, you can temporarily close the CBD, pass a catheter and do a cholangiogram.
Yes, sir.
But in laparoscopically, a choledocoscopy is really required for confirming. So you have confirmed that you have done a complete clearance of CBD. You have done the cholecystectomy. Now you have an opening in the bile duct. How to tackle that opening in the bile duct? You have done a choledochotomy. How will you manage this choledochotomy?
So I will put a T-tube, sir.
One is put a T-tube. What are the other options? It's a PG examination. For MBBS, it is all right. For MS examination or DNB, I am not happy to stop at just saying I'll put a T-tube. Now there are a lot of other options. There are a lot of evidence to say that you may go differently because you have done a choledocoscopy. You have confirmed that there is no stone left behind. With the choledocoscope, you can inspect the ampulla. You find there is no distal obstruction.
Okay, sir.
So,
the primary closure of the...
Yes. So, I think in the PG level, the answer first should be, I'll do a primary closure, provided I have done a choledocoscopy. I have confirmed that there is no distal obstruction and there is no stone left behind. Primary closure is one of the more demanding procedure nowadays. People are doing primary closure. Second option is T-tube. Third option?
Third option.
Why remain silent? Third option is?
Can you put a stent?
Bilioenteric anastomosis. And there are some specific situations where you need to do a choledochostomy or sometimes choledochostomy. When you think it's prudent to do a bilioenteric bypass. There are some guidelines where you should do a bilioenteric bypass.
Sir, if there is a biliary stricture in the terminal part.
Yes. So there is a suspicion of a narrowing or there is an obstruction in the distal CBD. In that case, you have to do a bilioenteric bypass.
Yes, sir.
Or you are operating on a patient who has got recurrent biliary stones. You find there is biliary mud. So they are the patient who may develop further problem of bile duct stones.
Yes,
so in that case, if you do wide drainage, you can take care of that. So keep in mind that this choledochotomy may be managed either by primary closure, by closing it over a T-tube, or by doing a bilioenteric bypass.
Closure over a stent is also an option, I think.
Yeah, closing over a stent, yes. Any other question? We have gone beyond time. Sorry, 10 minutes. Sharon, you have any question?
No, sir.
Keep your mind open. Don't get biased with a particular diagnosis. Somebody told in the exam is CVD stone, so you stick to only the stone. No, you should keep your mind open on the background of the patient presentation you're finding in the examination.
Yes, sir.
Have you heard of something called an access loop?
No, sir.
You should read. Patient who has got some situations where there is extensive stones in the hepatic ducts, bile ducts, and patient is having recurrent stone formation. In that case, just doing a biliary bypass may not be enough. This patient may form recurrent stones. So you can approach the CBD by an endoscope if you have this access loop being made while doing primary surgery. So read about that, where this access loop can go. It can be deep to the skin. It can be the loop into the stomach. So we have some good number of patients in system where you have done this access loop, and it's very effective. The endoscopist can go into the bile duct through the access loop. They are all resistant cases of cholangitis with stone formation. Ramdi, we are doing routinely? No,
not routinely, but in rare cases when there is really recurrent. But we do it to the stomach, not skin.
Yeah, stomach. We do the stomach only.
Stomach.
Approach is good. They have very easily approached the bile duct to the stomach. Okay, thank you very much.
Thank you.
Anything in the chat box, Milind?
No, it's done. Nothing else.
Thank you. Thank you very much.
Thank you.